So she's a 75 years old lady. She suffers from dyspnea. She has the following risk factor: hypertension, diabetes, also morbid obesity, with a severe COPD with this finding that you can see there. And she also suffered from venous disease with the deep venous thrombosis 2 years ago. Next. In the EKG, she has a normal sinus rhythm with incomplete right bundle branch block. Nothing special about the blood test. The echo Doppler unveiled a severe aortic stenosis with a tricuspid valve with an area of 0.7, excuse me, with gradients of 62 and 40 as a mean gradient, with a Vmax of 4.0. With preserved left ventricular ejection fraction. Clinicians at the beginning were a little confused about the symptoms, so they asked for a stress test echo, which showed the dyspnea with arterial oxygen desaturation during exercise. So we interpret this due to the severe aortic stenosis, so they send the patient or refer the patient for evaluation. Next. She underwent a coronary angiography in another hospital. She has normal coronary arteries. Unfortunately, the quality is not good enough for showing to you today. So, but we accept the angiography, which is normal. Next. So we did an angio-CT. She has these measurements done at the core lab of the valve center. The annulus measurement was with these diameters 20 and 24.4. With a perimeter derived of 22.7, with an area of 377, with a perimeter of 71. Next. This is the LVOT with a little bit calcium below the left coronary sinus, with these measurements at the sinotubular junction that I will show you in the next slide. Next. So we were discussing with Dr. Fernando in the morning, and we did our own measurements. And here we find the different measurements. You can see the area is 424. Fernando, would you like to comment something about this?
Yeah, this is a good point to discuss, because sometimes we find some discrepancy in between the core lab analysis and our analysis. So it's a good exercise to perform our own analysis, just to be sure of which valve needs our patient. So in this case, we have changed our mind to use a 24.5 size Myval.
So here is the ostium height, 11.8 for the right, 11.6 for the left. The ostium of the right is quite big. The left is not that big, but for this valve is enough, and Fernando agrees on not protecting this coronary ostium. Next. So here is what Fernando was saying. If you want to comment, we have some calcium, but not too much.
Not too much. So a very important comment for balloon expandable valves is to have a very accurate measurement of the size, probably more important than self-expanding technologies. And second, in this case, without too much calcium, better to have a good size, because we don't want the valve to embolize.
So these are the potential vascular access, quite acceptable, not too much tortuosity, good diameter, 7 in the common femoral artery on the right side that we have chosen for implantation of the valve. Next. Note calcium. The aorta is, I would say, quite straight, nothing or no important angulations there, no significant calcifications. Next. So according to this suggestion, we have prepared this patient for transfemoral, and we're also going to discuss with Dr. Cura about the direct implantation or pre-dilatation. So here we put a femoral introducer for a transient pacemaker that we are going to pace in from here, and also we will leave the wire at least for 12 hours to check if any new conduction disturbances would appear. Remember that we have talked in last session that previous conduction disturbances are the more important predictor for new or worsening. So we have done a crossover, and we have the angio there. We use a seam 2 with the extra stiff Terumo wire. Then we advance it, we cross with the 018 wire, we put 2 proglides here, sorry. And we have left an 11 introducer set because we are waiting for 20 or 25 minutes before starting the procedure. So here is the introducer. Any special characteristic that you want to point out, Fernando?
Yeah, this is a expandable sheath. So it is 14 as it comes. And then before advancing with the valve, we will open with the 18 French dilator.
We will introduce this catheter. We exchange for extra stiff Amplatz wire.
So this is very important to, whenever we use an introducer, a large bore introducer, it's important to use a hard wire, extra support wire. So this is also our practice to be sure that we don't have any problem.
Okay. So we are dilated the orifice, the
skin and the orifice.
And now we are put the introducer, and also Fernando recommended us to suture to fix.
Yeah, because sometimes the sheath may come back, and it's better to have it sutured to the skin in order to avoid that and to keep because you don't want to advance the sheath without the dilator. This is very dangerous. So whenever we have to advance the sheath, we have to put a dilator inside.
Now we are going to cross the valve. As usually, we try it from the beginning with the pigtail. If we cannot, we can use the Amplatz catheter.
We will see how Cacho crosses the valve because he has a special way to cross using the JR. Is that right? A JR?
No, the pigtail.
Okay. The pigtail directly.
I would say that probably in 80% of the cases we are successful in this simple maneuver. You have to take some time.
So this is
you know that why I'm doing this is because at the beginning we have problem with wires, with all the wires, and before we have dedicated wires, so we scared about that. So we try to be as less aggressive as we can. So we try to go to the apex of the valve there, like something like this. Most of the cases we can, but some days we have to change for the regular technique.
Which wire is that?
It's a regular
J wire.
Yes.
No, and also the mean gradient is 47, so this is very, very tight.
Yeah, maybe we cannot waste too much time. Give me the Amplatz. We will go with the regular way. So let's go with a via recta. Now we are changed for a straight wire, 35, not hydrophilic. Hello, venir. Dale. Here is where we have to take care. And when the catheter jumps, if the wire is looped, it's okay. If the wire is not looped, we have to be careful. We are jumping against the wall. Give me the Amplatz. I will give some loop here so we can.
It's triggering some arrhythmia because, of course, we see the tip of the catheter touching the LV. So we will be very careful.
I think we can start preparing the wire. Fine. Amplatz just to change the catheter.
Oh, okay.
Come on.
We use the long J wire for this.
Okay. Now give me the pigtail. And bring the other pigtail. Fernando, how frequent in your center are you using, let's see, balloon expandable versus self-expandable valves?
I would say that,
give me a second.
Yeah.
We have to say that we have explained before that in Argentina, many times physicians don't decide which device can use because health insurance companies send to us. But
yeah,
beyond that,
yeah. So beyond that, if I have to choose, I probably would choose for a balloon expandable in 70% of cases and self-expandable in 30%. In Argentina, we have availability of Myval and Edwards. We are very comfortable with Myval, so we have been using for the last couple of years. Second valve probably, in between Accurate and Medtronic and Evolut. But as you say, many times we cannot choose, so we have to adapt the valve to the patient, which is better to go inverse. Yeah, advantages, of course, of balloon expandable valve is the rate of pacemaker, and that helps us to discharge the patient the next day in the majority of cases. Although some cases we can discharge the patient the same day. So it's in that way, it's reduce also hospitalization. So working projection.
We will do both.
Okay, great. So we can see if we have both nice working projections. So first of all, we go with cusp overlapping.
Okay.
Which is 8 RAO and caudal 27.
Let me check. I think it's a very nice projection. Maybe we can do another one because we have a lot of water in the system. Okay, Beautiful. Let's go to the other. Here, this is the coplanar view.
Okay, yeah. It's very, you cannot see very well the right, but we can see from here.
There, exactly. You can see the right.
Yeah, it's not
in the middle.
Yeah, very.
So it's zero, at 0, 0.
Good view.
So when valve is ready, we are going to pre-dilate. So let's go people 180.
What? So these are 18 balloon.
This is 18 balloon. Yeah.
Is the, how is the name?
Inflation.
Mammoth. Mammoth balloon. So we are pacing the patient.
Okay, stop pacing.
Stop. Cortar.
Stop.
Marcapaseo. Cortar marcapaseo.
Cortalo. Cortalo del todo.
Good.
Perfect.
So good shape of the pressure and of the balloon.
Que no se venga para atrás la guía. Dejarla bien. Yeah. So Juan is going to bring the valve. Carlos is trying to leave the wire as distal as he can. So to have enough space for the nose cone. So we are doing.
Do you have the introducer? Have you dilated with 18?
No yet.
So we have. So we have
give
to.
Me the 18
first of all, the dilator.
Yeah.
So we will. Some people doesn't expand the dilator with the 18, as we have talking yesterday with a group. But we always increase the size of the introducer with the 18, so the valve can navigate easier.
Teneme el sheet, Franco. Okay, Fernando. So let's go here.
We will check the valve before going out of the introducer.
Okay. Pone AP.
Just to make sure that it's in between the balloon. So go.
Mostrarme abajo. Un poquito más.
Okay, there. You see the tip of the introducer there?
Mostrame que se vea el introductor.
No, could be even close.
Escúchame a mí. Soltar. Ahí. So we can see both the sheath and the wire.
Right. So we'll see. Let's see. So as you see, this is a check that the valve is in the middle of the balloon because you have the points that are very well distributed. So this is a good checkout. And now we know that we are fine. Great.
So probably we can describe something here. First, we don't have to load the valve as we had to do with
Exactly.
the other balloon expandable valve. And also the sheath is a deflectable sheath in the same way. Is that correct?
Exactly.
And do we have to pull here or something like this before delivering the valve or no?
No, we only have to advance.
Okay.
And before crossing the arch, we have to deflect
Okay.
50%.
Mostrame arriba.
So at this point,
Okay.
we deflect 50%.
Now we are deflecting. Almost in.
Great, great. This is
Let's
usually-
zoom. Yes, guarda.
So now we will pay attention to the position.
Mini test, mini, Franco.
Pero andate a la proyección.
Vamos a la proyección de trabajo, oblicuo a
So
derecha.
we'll go always to the working projection, which here in the cusp overlap,
I think we're a little bit deep.
we are deep, exactly.
So here we are in the,
Yeah.
darkest second band.
Let's do angio just to make
I will
sure.
show you.
Angio.
See,
Yeah, it is low. I would go like 1 millimeter
okay.
above that.
We can pull the wire a little bit.
Oh, it go below. It
Yeah, because I pull the wire.
even you're pushing the wire just to take the valve.
Yeah,
Good. That's
so
a good.
I think it's
Right.
there. Test. Okay, I like it, Fernando,
It's a good
there.
place. It is
Yeah?
a good place. Yeah.
Okay, now we can leave the pigtail there. Do you agree?
Yeah, you can leave it.
Yeah. So second, we will start pacing at 180, 180. Now go. Go all. Okay. And pushing a
Button.
little bit, deflate. Perfect. Stop.
Very nice. Very nice.
And now we can do an
Pressure is
ancho
fine. We
here.
have a nice diastolic pressure also.
Let's go. I think it's beautiful. Fernando.
Beautiful.
Foreign actions are perfect.
I think this is a
height
great view because there is no parallax.
Let's
So
go to the AP view. Okay.
beautiful.
Anterior.
Even you can pull the wire. You don't need to.
Do you,
This-
I like to measure the gradient.
Oh
Do you
yeah,
like
good,
it?
good
Yeah.
idea, good idea.
Yeah. Let's go for 0 again.
Which is the second pressure? The second pressure.
Let me check the zeros before.
So one is LV.
Yeah.
And the other one is the
Aorta.
radial.
Yeah, No.
Oh,
it's
aortic. Great.
No gradient at all. Very nice diastolic. Very nice notch indentation.
Beautiful
So now we can
Shape.
pull the wire.
of
Give me
hemodynamics.
the shape wire.
No error at all.
At
So
all.
this is the
Ahora
beautiful
sí.
thing.
¿Puedes ver el eco?
And the position is great. It's like 3 millimeters below. You have a great access to coronary arteries because the cells are very large in the top, as you see.
Now we can see what she can see on the echo.
So what is she gonna check? So she's gonna check, first of all, to the gradient, the amount of AR, mitral valve function, and if they have any pericardial
Effusion.
effusion.
So from the echo point of view, you probably have seen that the peak gradient was 15 by echo, 7 the mean, with a good valve area and not regurg at all. So guys, our job is done here. Dr. Carlos Fava is gonna fix the wire of the pacing for 12 hours or at least, and we will pull out or withdraw the contralateral sheath. While Franco, although we don't have a bleeding, we still compress probably for 10 minutes,
Yeah.
additional 10 minutes.
Good, excellent.